Functional Movement Screen, or FMS. Gross limitations of functional movement patterns, even if pain-free, can cause compensation and substitution, leading to poor efficiency, secondary problems, and increased injury risk. The goal of all of our movement in either preventative exercise or rehabilitation exercise is to train the body for optimal performance. Dysfunction, instability, and a decrease in range of motion changes our ability to select the most optimal movement strategy and therefore may affect performance. The goal of the clinician is to identify these areas of deficiency and address them through exercises and interventions. In order to better understand the system's philosophy, we have devised what we call the performance pyramid. The performance pyramid is a simple diagram constructed to give you a mental image and understanding of human movement and movement patterns. It is constructed of 3 levels building upon one another. Each of these levels represents a certain type of movement. The pyramid must always be constructed from the bottom up and must always have a tapered appearance, a broad base, and a narrower top. The first pillar is the base platform or foundation. It represents the ability to move through fundamental patterns. This is also known as functional movement. The second pillar is concerned with performance. Once you have established your ability to move, you must look at how efficient you are at that movement. This movement efficiency is defined as power, or also known as your functional performance. This is not your specific power. This is your general, measurable power, or gross athleticism. An example of a test of gross athleticism is the vertical leap. First of all, gravity affects all bodies equally. Therefore, the vertical leap does not discriminate unfairly against body size. Secondly, even though jumping is very important in some sports such as basketball or volleyball, and rarely, if even considered in others, cycling or marathon running, it demonstrates your ability to produce or generate power. At the top is the functional skill. Functional movement is defined as mobility, stability, and assessment. Mobility is measured through range of motion and flexibility. Stability is assessed with core stability and neuromuscular control. And we can use an assessment tool, also known as FMS, or the Functional Movement Screen. We must answer this key critical question. Are we building strength and conditioning, rehabilitation, fitness, and skill on top of dysfunction? Ideally, FMS would be introduced as part of a pre-placement or pre-participation examination to determine deficits that may be overlooked during the traditional medical and performance evaluation. Muscle flexibility, strength imbalances, or compensation due to previous injury are all acknowledged as significant risk factors for injury. In many cases, the FMS will pinpoint those issues that may not be identified in other standard evaluations. The Functional Movement Screen will identify functional deficits related to proprioceptive, mobility, and stability limitations. If these risk factors can be identified and addressed using FMS, then decreases in injury and improved performance should follow. The FMS can also be used to rescreen for feedback every 4 to 6 weeks, or when an improvement is seen in the priority movement pattern. Rescreening provides feedback into the effectiveness of the current program design and provides insight on how and when to move to a higher level progression or a new priority movement pattern. The Functional Movement Screen, also known as FMS, was developed by Gray Cook. FMS is a screening tool used to evaluate 7 fundamental movement patterns in individuals with no current pain complaint or musculoskeletal injury. The FMS is not intended to diagnose orthopedic problems, but rather to demonstrate opportunities for improved movement in individuals. The screen is designed to place an individual in extreme positions where movement deficits become noticeable if appropriate stability and mobility are not used. Even though individuals are performing an activity or sport at a high level, it has been observed that many of these same individuals are limited in fundamental movements. This leads to the use of compensatory movements in order to achieve or maintain the level of performance needed for the activity. The ineffective or inefficient use of compensation during movement will lead to poor biomechanics that limit gains in performance and reduces the body's ability to remain adaptable and durable against the risks involved in the activity or the sport. One famous quote from FMS is, "It is not natural or efficient to build capacity on incompetence." You may also hear of SFMA. The Selective Functional Movement Assessment, or SFMA, is a movement-based diagnostic system which systematically finds the cause of pain, not just the source, by logically breaking down the dysfunctional movement patterns in a structured, repeated assessment. The Selective Functional Movement Assessment, SFMA, was also developed by Gray Cook and colleagues, the same group who developed the functional movement screen. The SFMA is meant to be used in a diagnostic capacity for musculoskeletal assessment when pain is present. The SFMA is a clinical model used to assist diagnosis and treatment of musculoskeletal disorders by identifying dysfunctions in the movement patterns. It uses a series of full body movements to identify possible movement dysfunctions. The purpose of the SFMA is to assess the quality of the movements. It is not about how many repetitions the person can perform, but rather the quality of the movement pattern. The SFMA helps to expose possible asymmetries and pathological movement patterns as the root cause of a painful problem. This will, in turn, help guide a treatment plan to restore pain-free movement and function. To understand how to use the tools properly, it is important for the clinician to understand the terms tightness and weakness within the SFMA framework. The SFMA system understands tightness as an issue with tissue extensibility and/or a joint mobility dysfunction. Weakness, on the other hand, refers to the stability of the joint and its associated motor control. In order to achieve optimal functional movement, we need to have a balance between mobility and stability. We need to have our tightness equal our weakness. For example, if the hamstrings seem to become tight when the core is too weak to control the pelvis. In this instance, targeting the tightness will only result in a short-term gain at best, so stretching the hamstrings probably is not going to fix this issue. SFMA versus FMS. Many clinicians confuse the Selective Functional Movement Assessment, or SFMA, with the Functional Movement Screen, FMS. Both tools are part of the same functional movement system created by Cook and colleagues, but their fundamental purposes are quite different. The SFMA is meant to be used in a diagnostic capacity designed to identify musculoskeletal dysfunction among individuals affected by pain, whereas the FMS is a screening tool, not intended for diagnosis. The FMS aims to identify imbalances in mobility and stability during functional movements. There are 7 movement patterns assessed in the FMS: the deep squat, hurdle step, inline lunge, shoulder mobility, active straight leg raise, trunk stability push-up, and rotary stability. The scoring criteria. The FMS uses a simplistic grading system. Each individual movement pattern has certain criteria that must be accomplished in order to obtain a high score. The scoring is broken down into 4 basic criteria. A 3 is given if the individual can perform the movement without any compensations according to the established criteria. 2 is given if the individual can perform the movement but must utilize poor mechanics and compensatory patterns to accomplish the movement. 1 is given if the individual cannot perform the movement pattern, even with compensations. And a 0 is given if the individual has pain during any part of the movement. There are 5 movement patterns which require bilateral testing. This will result in 2 scores for those patterns. The lowest score is recorded for the final score. However, for assessment and data collection purposes, both scores are needed. 3 tests, the shoulder mobility, trunk stability push-up, and rotary stability, have clearing tests associated with them that are scored as pass-fail. If a person fails this part of the test, then a 0 is given as the overall score. Asymmetry is what we're looking for. Musculoskeletal asymmetry is a well-established risk factor for injury. We'll discuss further on the next slide. There was a research study done by De Lamont in 2016 and their colleagues. A total of 356 Marines completed FMS testing, with 53.1% of Marines scoring less than a 14 on the FMS scale. More than 72% of Marines had right-left discrepancy on one or more FMS tests. The shoulder mobility test yielded the highest percentage of discrepancies. The majority of Marines, 62%, reported a history of one or more previous musculoskeletal injuries in the past 12 months. Of those reporting a musculoskeletal injury, 40% were unable to participate in regular activities for 1 week or more, and 10% reported that they had not returned to previous injury levels. Previous injury is the strongest risk factor for future injury in sport. It has been proposed that motor control changes, such as movement limitation and asymmetry associated with injury and pain, may be perpetuated as part of an individual's movement strategy. The results of this study suggest that fundamental movement patterns and pattern asymmetry are identifiable risk factors for the time lost during injury. Another study by Kiesel, Butler, and Polinsky in 2014 looked at NFL football players. If an FMS score was less than 14 and there was asymmetry, then the probability of an individual suffering time-lost injury increased from 15% pre-test to over 50%. This study had a specificity of 0.87, which is pretty high. These scores were improved with specific off-season training programs developed through SFMA techniques and assessments. There's pretty good intra-rater and inter-rater reliability for the FMS testing. 10 studies were evaluated for inter-rater reliability of the FMS. All studies examined the reliability of scores of more than one examiner grading the same participants. Significant differences were seen in the characteristics of the raters included in the study. 9 of the 10 studies found acceptable inter-rater reliability, with confidence intervals ranging from 0.76 to 0.98. There were 5 studies that measured inter-rater reliability among raters with varying levels of FMS experience. Only one of those found unacceptable inter-rater reliability. The interclass coefficient was found to be at 0.81, indicating acceptable intra-rater reliability. 9 studies with a total of 2,696 participants were identified that evaluated the injury predictive value of the FMS. All studies, per the inclusion criteria, evaluated healthy people before participation in their respective activities. All 9 studies included in the quantitative synthesis compared participants who scored less than 14 with those who scored greater than 14. This cutoff was first established by Kessel in 2007, in which a receiver operating characteristic curve of their data showed that a cutoff of less than 14 maximized sensitivity and specificity and was affirmed in later studies. Looking at balance and asymmetry using FMS, we're looking to improve performance and avoid injury by eliminating asymmetries. Understanding balance. We need to understand where athletic movement originates, how does it respond, and how can it be improved. Testing for asymmetries. We want to use the functional movement screen when we can perform the screening techniques. The following are the 7 techniques that are utilized for the FMS screening. The deep squat pattern challenges total body mechanics and neuromuscular control. We use it to test bilateral, symmetrical functional mobility and stability of the hips, knees, and ankles. The dowel is overhead and requires bilateral, symmetrical mobility and stability of the shoulders, the scapular region, and the thoracic spine. The pelvis and the core must establish stability and control throughout the entire movement to achieve the full pattern. The hurdle step pattern is an integral part of locomotion and acceleration. This movement challenges the body's step and stride mechanics while testing stability and control in a single leg stance. The hurdle step requires bilateral mobility and stability of the hips, knees, and ankles. This test also challenges stability and control of the pelvis and the core, as it offers an opportunity to observe functional symmetry. The inline lunge pattern places the body in a position to simulate stresses during rotation, deceleration, and lateral movements. The inline lunge places the lower extremities in a split stance where the upper extremities are in an opposite and reciprocal pattern. This replicates the natural counterbalance the upper and lower extremities use to complement each other, as it uniquely demands spinal stabilization. This test also challenges hip, knee, ankle, and foot mobility and stability. The shoulder mobility pattern demonstrates the natural complementary rhythm of the scapular-thoracic region, thoracic spine, and the rib cage during reciprocal upper extremity shoulder movements. This pattern also observes bilateral shoulder range of motion, combining extension, internal rotation, and adduction in one extremity, and flexion, external rotation, and abduction of another. The active straight leg raise pattern not only identifies the active mobility of the flexed hip, but it looks at the core stability within the pattern, as well as the available hip extension of the alternate hip. This is not so much a test of hip flexion on one side, as it is an appraisal of the ability to separate the lower extremities in an unloaded position. This pattern also challenges the ability to dissociate the lower extremities while maintaining stability in the pelvis and the core. The trunk stability push-up pattern is used as a basic observation of reflex core stabilization and is not a test or a measure of upper body strength. The goal is to initiate movement with the upper extremities in a push-up pattern without allowing movement in the spine or the hips. The movement tests the ability to stabilize the spine in the sagittal plane during the closed kinetic chain, upper body symmetrical movement. The rotary stability pattern is complex, requiring proper neuromuscular coordination and energy transfer through the torso. This pattern observes multiplane pelvis, core, and shoulder girdle stability during a combined upper and lower extremity movement. The movement demonstrates reflex stabilization and weight shifting in the transverse plane, and it represents the coordinated efforts of mobility and stability observed in fundamental climbing patterns. scoring the test, and then designing a program. We use specific guidelines for exercise selection. We need to ensure that a program is proprioceptively rich. It needs to be safe, challenging, and stress multiple planes. If we can incorporate multisensory environment, that is even better, and it needs to be activity specific for the patient. We can have a progressive functional continuum. We progress from slow to fast, simple to complex, known to unknown, low force to high force, eyes open to eyes closed, and static to dynamic. The goal of the program should be to develop optimal levels of functional strength and stabilization. The goal of the program should be to focus on neural adaptations instead of absolute strength gains. Developing strength should be a secondary benefit of FMS training. We also need to increase the proprioceptive demands, and we need to focus on quality, not quantity. Poor technique and neuromuscular control will only result in poor motor patterns and stabilization, which will then likely result in injury. We need to make sure that our patients are not learning these patterns as they're training. The focus of the technique should be on the function and the quality. Some questions to ask yourself. Is this exercise dynamic? Is it multiplanar? Is it multidimensional? Is it proprioceptively rich? Is it systematic? Is it progressive? Is it activity specific? And is it based on functional anatomy and science?